Welcome everyone. Happy New Year. It's nice to see everyone back. And I don't know why I got the pleasure to actually introduce the last speaker last year and the first speaker this year. And it's two friends, so it's actually extra exciting. So one really came for the December.
Oh, very nice.
Anyway, so I want to introduce Dr. Witteman, and I'm really, really excited that now it's like Holly came here today to give a speech. So we to give the talk for THETA round. Holly is Associate Professor in the Department of Family and Emergency Medicine at the University of Laval in Quebec City, and so she came all the way to Toronto today for us. She directs the research unit within the Faculty of Medicine's Office of Education Professional Development. She's also a scientist at the research center that I cannot pronounce. You jump in. Okay, perfect. At the University of Laval, at the new Institute of Primary Care Research, and you're also affiliate investigator at the Ottawa Hospital Research Institute. And you guys can read all about it. She's got an interdisciplinary background in human factors engineering and social sciences, and it's actually really, really exciting in terms of the work that Holly is doing. So it's all around design and evaluating digital and other media in health decision making and how it can help patients making decisions around I know about vaccine decisions, so kind of get vaccinated for influenza or not get vaccinated, and see kind of in an app what are the consequences of your decisions for yourself and others. So it's incredibly exciting stuff. I know Holly's in graduate school, and I was actually going to say that. I think the first time I met you was in the Intro to ClinEpi course, and I remember that. I'm not going to say how many years ago, but it's a long time ago. So all really exciting, and I'm happy you're here today. Before we start, we do the same thing as every time. So we go around the room and everyone please introduce yourself. I'm going to start. I'm Beata Sander. I'm a scientist here at THETA. I'm also an associate professor at the Institute for Health Policy Management and Evaluation at the University of Toronto. And then Joanna gets always the second position here in the introduction.
I'm Joanna Bieletsky. I'm a research librarian here at THETA and the online moderator for our 8 participants.
They're the only ones who don't need to introduce themselves. Pete.
I'm Pete Leisure. I'm a scientist at Sammy Latner at Mount Sinai.
Charles Wright, the past chair of Ontario Health Technology Assessment Committee.
Welcome. You
research associate at THETA.
Jim Wiggach, Director of Research at LTOI. What's the name?
I'm Leticia. I'm a PhD student from Brazil.
I'm Eva. I'm a research associate at THETA.
I'm Melissa. I'm a researcher and designer at Witteman here at
William Moore, assistant professor at University of Washington.
I'm Cameron.
I'm Kathy Kastner. I'm none of these things. I am a health blogger and avid tweeter in the end-of-life space with technology as a side.
I'm Alex. I'm a health economist at THETA. I'm Andrew. I'm a PhD student here at THETA.
I'm Rafael. I'm a postdoc fellow at THETA.
Murray Frank, I'm Director of THETA. I'm Jim Owen, with ABIS as a clinical research manager at THETA and part-time assistant professor at Master.
I'm Sheila. I'm a grad student at THETA. I'm Laura. I'm also a grad student at THETA.
Marina Richardson, grad student at THETA.
Yeah, everyone. Thanks, everyone, for being in the room. A lot of new faces. Really exciting starting year this way. And I also noticed we are kind of color coordinated today. We did not agree on that previously, but great. Welcome, everyone on the line. I hand it over to Holly. Questions at the end, please. That's the only request. All right. There you go.
Are you feeling
Yeah. Yeah. We're good?
Yeah. All right. So I'm really glad that we have such a homogeneous group because that makes it really easy to talk about things. It's wonderful to see such a broad, diverse group of people, and I'm really pleased to be here. Thank you so much for the invitation. It's an honor to be here. I remember when my husband used to work at THETA and used to organize these rounds, and so he gave me a really hard time for not responding very promptly to Joanna's emails. So as Beata noted, I'm here from Quebec City. Université Laval is in Quebec City, or in English you would call it Laval University. I always tell people this because more than once someone has gone to Laval, the municipality north of Montreal, and been like, So I'm here. Where's your office? Different places. Laval was the first bishop of Quebec, and there are multiple things named after him. So in terms of declarations, what I'm going to be talking about today is a long sort of series of ongoing work and methodological stuff, which draws on a lot of different projects that I've done. So I acknowledge all the people who have given us money to do work, which is really, really very much appreciated, because without that we can't advance things. And I also want to acknowledge my wonderful team. They're all up there in the photo. That's a photo we took this summer of the staff and students that I have the great privilege of working with. So my work has always been sort of on the fringe of fringe fields. I remember when I was a student and I would meet with Murray, and Murray would say things like, Holly, you need to focus. And I never really did. And I kept doing things at the fringes and pulling them all together in weird, bizarre ways. And so when Beata first asked me to give a talk, I was really honored to be asked, but I also sort of said, well, what am I going to talk about that's relevant to people at THETA? So we talked about what are the things that might be useful for people here for me to come and talk about. And what we agreed was that I would talk about user involvement in general. And so I'm going to sort of talk about two types of involvement. And one of them is in research in general, and the other one is in development and evaluation of interventions. And for both of those, I'll talk about frameworks and models, and then some more practical stuff. So that's a lot to get through, so I'm just going to dive right in. As was noted, I'd like to hold questions until the end, but if you have a question of clarification, do feel free to ask. So the first thing I'm going to talk about is patient involvement in research in general. And the thing that's important for me to note when I talk about that is sort of where I'm coming from with that and what are the things that influence me. At the very top of the list is the fact that long before I became Dr. Witteman, I was a patient for decades. And so a lot of my perspectives on patient partnership, I realized as I go forward, really come from those experiences more than they come from the world of research. But added on to that, I have added some experiences in terms of, I co-lead the patient engagement strategy for the Diabetes Network. So I'm sort of like a bridging person because I speak both languages, literally and figuratively. The network itself runs both in English and French. I have held a couple of awards from the Patient-Centered Outcomes Research Institute in the US, and I've always worked with patient partners. That's just how you do things in human factors engineering. If you don't involve the people who are going to use your things, you're not going to design good things. So that's sort of the background that I bring to this. And so when I think about the term, I actually don't really like the term patient engagement. And one of the patient partners on one of my projects said at one point, he's like, you know, the engagement is over. We're partners now. And yet the term that is used in Canada is patient engagement. So that's what I call it, even though it makes me uncomfortable. But when we talk about patient engagement, the goal is really to have research reflect what matters to people who are supposed to be served by that research. And that's really what it's about. And how you do that is generally, what is recommended is to have patient partners involved at all levels and to guide decisions about how the research goes forward. So what does that mean? And how do you put frameworks around that? So when I was thinking about, okay, what are the frameworks and models that would be useful to mention that could be helpful for people to have in the back of in their back pocket in case they ever need a framework for this? So there are three particular ones that I'm going to mention. There are a lot out there, but there are three that I'm going to mention. And one of the first one is this framework by Carmen and colleagues. So it's published in Health Affairs. And what I really like about this one is that they very clearly distinguish the continuum of engagement and what it means to be consulted versus to be involved versus to be partnering. And they're very clear about that. And there isn't a row for research, so it's not quite as clear. Unfortunately, this is as clear as this image gets. It's blurry to start with. If you go and read the journal article, you'd be like, oh, wow, this was blurry from the start. But the point is that there are different levels at which people can be involved. So this is a good one to know. The other framework that's good to know if you're doing this kind of work in Canada is the Strategy for Patient-Oriented Research Framework. I was going to make my usual joke when Beata couldn't pronounce Seachskul, which is that I really hate acronyms, so I decided to work in medicine and in French. And yet, especially I find in this kind of research, it's ridiculous the way these acronyms proliferate, but that is the term that is often used in Canada, is SPORE. So the SPORE framework, the Strategy for Patient-Oriented Research Framework, has 4 guiding principles. So inclusiveness means that you're including a diverse set of perspectives. Support means that you provide support for people so that it is so that they feel comfortable, so that it's a safe space to talk about things, about your own experiences, about your health, because that's difficult emotional work to do. Mutual respect means everyone respects each other from their perspectives as a researcher, as a health professional, as a patient, as a caregiver. And co-build means that you work together to make decisions about how the research goes forward. So everything from what is the research question that you're going to tackle to, how are you going to recruit people? What are you going to put on the materials, that sort of stuff. And the other, what even more useful, I think, than the guiding principles for this framework are they came out with, well, what does success look like? And I think this is a really helpful way to think about things if you're ever going to do a project where you're going to use these kinds of methods, is to think about, okay, well, what would it look like to do it well? And this is how they define that. This was a multidisciplinary group, including patients and caregivers, who defined, okay, this is what success looks like in patient-oriented research in Canada. And so they've sort of broken it down, okay, this is what we would want to see. Inclusive mechanisms and processes, multi-way capacity building. So that means that it's not just that people who are new to research get offered orientation to research, but also that researchers are offered orientation into how to do this kind of work. Multi-way communication and collaboration, that people's experiences are valued as evidence, that patients and caregivers inform and direct the research, and that there is this sort of shared sense of purpose for everyone. These are kind of broad and abstract. The third framework that I'm going to point you to is this framework that was developed by Clay and Hamilton, who works with Linda Lee out in BC. And what I really like about this one is, so first of all, I like the way that they developed it, but secondly, what I really like is it's incredibly practical. So there's a workbook that goes with it. So if someone's ever planning a project and they need to start to think about this, there are recommended questions for discussion. There are sheets that you can fill in. And it's just a really nice way, I think, to think about it. It's an accessible way for someone who is not entirely sure, or even who's done this before, but could, maybe benefit from some guidance from other people of what are some things that I might not have thought of in the past for setting up projects in order to do a good job of partnering with patients. So those are the 3 frameworks that I think are, that I like and that I think are the most useful in terms of practical methods. They're not the only frameworks out there. And if you are doing this if you want to involve patients and caregivers and other people in your work, there are other ways and other frameworks out there and other terms to know. So other things that I would recommend people always making sure that they look at are the frameworks that are made available in the US with the Patient-Centered Outcomes Research Institute. In the UK, they have this framework called Involve. And just being sure that you understand the terminology around it. So there are other terms that are related to patient partnership and patient engagement that are not quite the same thing, but patient and public involvement, community-based participatory research is another kind of research that really works with people to work on things that matter to them. Participatory action research is very similar. And just being aware of lingo is another thing to be aware of, that different countries tend to use these terms differently. So I mentioned, I don't really like the term patient engagement, but that is what we say in Canada. So those are the terms that I use when I'm talking about this. In Canada, we talk about patient partners, especially. In the US, patient partners are used, but also patient advocates, which means something a little bit different. So here we would interpret advocates as someone coming in with a particular agenda, whereas it doesn't necessarily mean that in the US. In Australia, they use the term consumers. So just knowing that even though there are different words, it actually means the same thing. It's just that different countries have different ways of talking about this. In terms of models for this kind of work, basically what it means in a research project are that there's sort of this spectrum of models that you see. And it can start from anything from an advisory panel, where this panel of people meet separately. They might meet with the, principal investigator for the project, but not necessarily with the rest of the team. And then there's a spectrum all the way through to full integration, where you have patient partners at every level, they're at every meeting, and they're full members of the team. And then there are hybrids in between. So just to be aware that there are different ways to do this, and the right method and the right approach for a project may vary depending on resources, depending on what the topic is, and a lot of other factors. So for me, as an engineer, I find I often end up looking at models and frameworks and then sort of stepping back and going, yeah, but what do you actually do? And what does this actually mean? It's nice to talk about mutual respect, but what does that look like? And what are the things that you can do to facilitate mutual respect? So this is a paper that I wrote with a bunch of colleagues through one of the projects that we had funded through the Patient-Centered Outcomes Research Institute. And it was sort of this long progress of sort of talking about, well, what are the things that are working in our project? What are things that we've done in other projects? What are the ways that we could do this better? What would we do differently in future? And we ended up coming to this list of things that we had originally intended to only use internally, and then went, well, actually, this might be useful to other people to share the lessons that we have learned over the course of this work and previous work. And so we were able to synthesize this into sort of 12 practical tips for how to make this work better. And they're divided into 3 groups. And the first group is around mutual respect. Starting with an in-person meeting, especially if you're going to be doing a lot of distance collaboration, teleconferences, video conferences, that sort of thing. If people haven't met in person, particularly when there might be power dynamics and hierarchies, it's really nice to start with an in-person meeting. Introducing yourself with stories rather than titles. And this was one because I think this is a hard thing sometimes, especially when you've been in academia for a long time, because when you're an academic or you work in academia and you say something like, I'm a research associate, that means something to you. That means something in your world. But if you're not in the research world, that doesn't mean anything. Like, what is an associate professor? What is an assistant professor? None of these titles actually mean anything if you're not in this environment. And so it's jargon, and it can create power imbalances that you really don't want to have. And so one of the things that we talked about a lot was about introducing yourself with your story of what brought you to this project. Why are you interested in this project as a human being, right? Rather than using titles. We tend to use titles in academia because they're useful shorthand in academia. But when you're bringing in people who don't spend their lives in academia, having a different way to tell that story that doesn't use that shorthand can be really useful. Talking about individual and project goals really clearly, right? And just having that clear from the outset of, okay, why are you here? What are your goals? And what are the goals for the project? And how well do those match with each other? And offering orientation to all. So I think sometimes what happens is that people think, okay, well, we're bringing in patients and caregivers and we have to train them in how research works. And that can be really problematic. And I think one of the things that is important to recognize is that this isn't training so much as orientation. Here's what the language means, here's what this jargon means, and also offering orientations to researchers and people who haven't done this kind of research before so that they're well equipped to do it too. Involving everyone. So the first thing about involving everyone is to offer compensation. I'm going to come back to this in a minute, so I'm not going to spend a lot of time on it now. To recognize people's contributions and efforts. And one of the things that I find, and because, as I mentioned, I have these sort of dual roles, where sometimes I've got a patient hat on and sometimes I've got my scientist hat on. The patient hat is actually a lot harder to wear. It's much more emotionally difficult to talk about your own health experiences, especially in a room full of people. You've got doctors there, and it's very emotionally taxing work. And so recognizing the contributions that people are making is really important. Inviting people to take roles. So meeting sharing is a really good way to make sure that everyone takes a role, especially everyone, like not forcing people into it if they aren't comfortable, but sharing the meeting sharing around really helps to democratize the group a little bit. And checking in with quiet folk. So sometimes, especially in larger groups, and this goes for, I think this is something that isn't really necessarily about patient-partnered research, just in general, this is helpful, but for me, when I'm running a project, something that I find really important and useful is to check in after a meeting with people who didn't say much, right? And just to see if there's something that, is there anything that they wanted to add that they maybe weren't comfortable saying, and that way we make sure that we really make the best of everyone's expertise. In terms of communication, being careful about labels, so the point that I keep making about patient engagement, asking people what would they like to be called, right? How would they like to be known? This is a really important way to think about how people are labeled. Avoiding jargon and acronyms is really hard. It's a really hard thing to do. It's easy to say, and it's really hard to do because you start to, these acronyms start to mean things to you, and so you don't even really recognize anymore that they're jargon. But in mixed groups, this is a really important thing. Occasionally regrouping in smaller, more homogeneous groups, and creating a visual map of the project. So these are the 12 things that we sort of came to as, okay, these are things that have helped us in this project, things that we wish we'd done in this project, things we've done in previous projects, just sort of the collective wisdom of a bunch of people who've done this work for a long time. A couple of key points for working with particular populations. So if you are doing patient-partnered work with underserved and underrepresented populations, there are other considerations to keep in mind as well. And some of the things that are general best practices that you see across projects and that seem to work better for this kind of work are to work with community-based organizations and to go to them rather than expecting them to come to you. And particularly if you work in a hospital, having meetings in a hospital can be really intimidating or just really uncomfortable for people who had bad health experiences. Building relationships of trust, it takes time. Unfortunately, in a time in which you have to apply for grants, this creates a constraint because you don't always have the time that you need to build those relationships. So working to build them over time is really helpful. And avoiding parachute research, where you go in, you get the data that you want, and then you leave and you never come back. And this is a really good way to burn any good relationships that you had so that you can never work with that particular population ever again. It's just a good general rule to make sure that results get back to the people who were involved in creating that knowledge. So compensation, I talked about this a little bit. This is something that comes up a lot. The thing to know about patient-partnered research is that patient-partnered contributions have value, and volunteer time is not really free. And if you rely on volunteers, then that means that certain types of that only the people who can afford to volunteer their time are going to be able to do it, which means that you only get a certain type of person. Also, having some people at this table paid while others are not contributes to power imbalances, and that's generally a bad sign. Having said that, compensation is not always desired and it's not always desirable. So this is not an easy thing, right? This is a tricky area. I co-chaired a task force in which we got all the different strategy for patient-oriented research and chronic disease networks together and said, okay, we've got all these different ways of doing this. Can we start to harmonize them a little bit? And so we wrote this document that's publicly available, and you can go look at it. And what it has in it is 2 potential models with numbers in them, because every time we would ask CIHR, they wouldn't give anyone numbers, and they wouldn't even say, well, this is the range of what people are offering for compensation. So we gave numbers. This is the range of what people are offering. Whichever model you choose, I think the important thing is to work with people to make sure it works for them. And as someone who has wrestled with this with my institution, what I will say is that institutions, sometimes it's difficult at first, but they can be convinced. You can bring them around. Consider things like work release time, that can be really important, but be aware of tax and benefit implications. Same thing goes for reimbursement. This is a really important thing, particularly if you're working with anyone who is not as financially well off, that, you know, waiting more than one credit card cycle to be reimbursed is a massive burden. And that should be avoided if at all possible. And if it isn't possible, make sure you tell people that they're going to have to wait, and then they can make an informed decision about whether or not they're willing to do it. Because it's really unfair to have people have to book their own flight and then wait to be reimbursed when they don't have the capacity to wait several credit card cycles. Reimbursement also means considering expenses that may be outside the norm for your institution. So for example, some people may need a caregiver to travel with them. They may need to arrange for childcare, elder care, respite care. Phone and internet service might not be a given for some people. And if you're working with Indigenous communities, there are particular gifts that are expected as part of cultural protocols that if your institution doesn't already have a mechanism for purchasing these gifts, that'll be something that needs to be worked out. And minimizing paperwork for people is a really good idea. I'm also going to point you to a paper that recently came out by a number of patient and caregiver partners who published about this, and they also give some particular recommendations about compensation. So I'm not an ethicist. I'm an engineer. So I'm not an expert in the ethics of patient partnership. But I think particularly for people who are working in health technology assessment, I know that this is an issue, especially around the professionalization of patient groups who are funded by, for example, pharmaceutical companies, and to what extent are they independent when they are, say, for example, providing a submission to CADIS. For anyone in the room who doesn't know what CADIS is, they're the Canadian Agency for Drugs. Thank you. Canadian Agency for Drugs, Technology, and Health. So, you know, being aware of these issues, I think is really important to know that who gets included when you are assembling groups of patient partners is incredibly important, and there are ethical concerns around that. Professional groups or formal patient organizations have pluses and minuses, and sometimes if their funding is not clear, there are ethical considerations around that. If you're offering compensation, who is paying for that compensation, and does this create any tension, any ethical tensions, and what are everyone's motivations for being there? So I don't really have answers for these questions, so I'm sorry to just sort of put the ethical questions on you, but just to be aware that this is one of those things that there aren't easy answers to this, but I think being thoughtful about it, we can come to ways of doing that really work. So that's the patient partnership in research in general. And now I was going to talk about something, it's actually not completely different, but I'm going to talk about user involvement in developing and evaluating interventions. So as Deanna mentioned, I'm trained in human factors engineering, and human factors is really about designing for the way people are instead of the way we wish they were, or adapting systems to people rather than expecting people to adapt to systems. A lot of the methods that we use come from product design. You can't see the quote at the back, I'm sorry. So I'll read it aloud. Customers don't care about your solution, they care about their problem. Right? And so it's sort of that way of thinking about it. Here's an example that comes up a lot in human factors. So these are called Norman doors. Don Norman was one of the founders of this field. And Norman doors are when you have doors that are hard to open. And doors are not a very advanced technology. Doors should not be hard to open. And yet, over and over again, what we see is people putting in doors where, for example, you have handles on both sides. And when you walk up to a door and it has a handle, what you naturally do is you grab the handle and you pull, but the door actually only moves in one of those directions. So the side that doesn't move towards you should not have a handle, and yet this happens over and over and over again. Does anyone recognize this? I took this photo here at the University of Toronto. No? Anyway, it's in the Department of Medicine. It's in the St. Mike's building, and I saw it and I just thought, why would you need a label for how to open a door, right? And I love this quote, a user interface is like a joke. If you have to explain it, it's not that good, right? So this is sort of one of the classic examples of how to think about how you design things for people rather than expecting people to adapt to your thing. So I'm going to talk about a framework called user-centered design. And an important thing when we talk about this is it contains the word user, which can mean different things in health research. So when I say the word user, what I mean is someone who uses something. So a technology, a system, a thing, or a procedure to accomplish a task or a set of tasks in pursuit of a goal. And the goal part is really important. And I think this is something that's easy to forget. So many years ago, my family up and moved from Toronto to Quebec City. It was a chaotic move. We lost our toaster, among many other things. Still don't know where it went. So we went to Canadian Tire and bought this toaster. It was cheap. And making toast for my children, and first thing in the morning, I'm really not a morning person. So put some bread in the toaster, and I press the lever down, and it springs back up. And I don't know what's wrong, and then I look at it and realize, oh, it's not plugged in. And, pardon me? Okay. So this was one of those examples where initially I was like, what is it? Oh. And what that tells me is that the product designer for this product was thinking about, what is my goal? Is my goal to depress this lever? No. My goal is to make toast. So if the lever depressed isn't going to make toast, then it shouldn't work, right? And there are other ways you could go about this, right? You could have a label on it. You could have videos for how to use the toaster. You could offer credits and continuing cooking education, right? Or you could design something that's more intuitive to you. So defining and aligning goals is one of the critical things if you're going to use these kinds of methods. And more I find, especially when I get invited to be on projects, this is like we sort of run through this first because I've had a number of experiences where the goals aren't aligned, and so we try to use these methods and it doesn't work. It doesn't work if the goals, if the user goals are not the same as the research team's goals, or if the designer, I think one of the classic examples that people talk about a lot is electronic health records. Right, where the goals of the person using it, usually a health professional, is usually patient care, and the goal inherent in the system is usually more around documentation, right? Or sometimes in the US it would be more around billing, documentation and billing. And that tension where the goals of the system are not the goals of the user is what creates a lot of the difficulty in using it, because it's not, you can't design, it's very difficult to design a system that serves multiple goals really well. You can usually only do one goal really well. So determining what are the goals and whether the user goals and the research team's goals are the same is a really critical first point. This is the framework that some colleagues and I synthesized from a lot of key literature in this area. I use the term user-centered design for the same reason I use the term patient engagement. It is the term that came first. It's the term that is most common in my field. None of these terms are perfect. And there are a lot of related terms. And for a long time, I would sort of put up this slide or a version of this slide, and I would say, in my opinion, these are all pretty close to each other. We recently completed a systematic review in which we went and looked at all the different projects that people have done when they've used these terms, and then looked at the methods they use and what did they actually do. And so now I feel a lot more confident saying these are all essentially the same thing, more or less. So user-centered design, I use that as sort of a broad umbrella term. Human-centered design is used often very interchangeably. And some people have made the argument that, you call it human-centered design to remind us that it's humans, and I really feel like if you need that reminder, that's a bad sign, right? You shouldn't need to be reminded that the people using your thing are people. Design thinking is another term that's often used, and the difference is really about disciplinary traditions. And then there are some other terms, so co-design, co-production, and co-creation. These are increasingly preferred terms in some countries. Participatory design, it's a little bit different, it's a slightly different, that's got more of a particular tradition to it. But the differences between all these terms generally have to do with two things. One is the disciplinary tradition. So like I said, design thinking, you will hear that more in business, right? Whereas you will hear user-centered design, human-centered design, co-creation in health research, right? The other difference is the location of power and responsibility. So co-creation implies that the power is shared. The power over and the decisions about what it is that you're going to do with this system, that is, you know, if you're doing a health services research project where you've got researchers and patient partners, that they have equal power to decide how the intervention is developed, right? What that means is also equal responsibility. So with power always comes responsibility, and so that's always a bit of a thing to think about is if you're going to say co-creation, that's great, but are you really ready to go all the way and actually do co-creation where you share power? So some key points about this framework. 4 key points. First of all, it's an iterative cycle. So there's no clear starting point, and that is explicit, and there's no clear end point, because you can start anywhere and you can end anywhere. When we talk about users, we talk about more than needs. So in health services research especially, it's very common to do a user needs assessment. When we, in user-centered design, we look at more than needs. In addition to needs, we talk about people's goals. I talked about that earlier. People's strengths and limitations, that's a really important thing. The context in which they might be using this thing, their intuitive processes. How do they do this now? Right? Like when you walk up to a door, what is your intuitive process when you see a handle? Prototyping early. So starting much earlier than, you know, you would typically develop something all the way and then you would have it all ready and you would run a pilot test. So in user-centered design, you start to show it to people much earlier than that, and observing rather than asking. So what I mean by that is observing users' interactions with a prototype is different than asking people what they think of it, right? And those are both good things to do, but you get different kinds of data from them. So here's an example process, and this is, this is not prescriptive. This is just a descriptive. This is one way to apply this framework, right? Would be to start by observing existing processes by shadowing people, right? Shadowing your users and seeing how do they do this now, right? They're dealing with this in some way. What do they do now? Doing some focus groups. This helps further understand the user. Creating personas, which are archetypes of your potential users. Then running a participatory design workshop with users and other experts. That's where you're developing a prototype. Testing candidate designs using think alouds. This is a method of observing how people respond to it. Interpreting those test results, which helps further understand the user. Refining the design, testing again, and repeating. So, like I said, this is all descriptive except for that 5th one, testing candidate design. And you don't have to use think aloud, but that is one of the things that's not really optional. If you're going to do this kind of work, there needs to be user testing. And what user testing is, and I mentioned this a little bit already, it's seeing how people respond rather than asking whether they like it and what they think. You can also ask them whether they like it and what they think, but it's really easy to fall into that and to stop getting the data about how they're responding. Based on the data that you get, you fix the problems and adjust the design accordingly. And it's a really efficient way to discover problems before launching an extensive pilot study or trial. And that's the real benefit of these methods, is that there's a term that's often used, fail early and fail well. Fail early means you prototype early and you discover the things that don't work early, and fail well means you learn from those things and you improve. The most useful feedback is often the feedback you don't want to hear, right? So I've had more than one, whoops, I keep hitting this mic, sorry. I've had more than one project where it's sort of like we're partway along, we've done a couple of cycles, and then it turns out, oh, you know what, this does not work at all, and we need to start over. But at least we only did a couple of cycles. We didn't take it all the way through to an RCT, randomized control trial. A good how-to reference that is rather tech-focused, but it's really accessible, if you're interested in this, is Rocket Surgery Made Easy by Steve Krug. It's very readable. It's not an expensive book. So when I say prototype early, these are actual examples from stuff that we've done in my group. This is what it looks like. We start with a lot of paper sketches. It's a really cheap way to start to workshop ideas and see how people respond to it and iteratively refine. This is a project that I'm working on with some colleagues in the US that they might be discussing right now, for all I know. I just sent this to them this week. So it's like, these are really rough mock-ups that start to get feedback from people very, very early. And something to think about as well is that in addition to think aloud, which is basically you put something in front of someone and you ask them to articulate what they're thinking as they're going through it, there are other methods as well. These are not necessary methods, but this is what we use in my lab. So we have a human-computer interaction lab where we have things like eye tracking and EEG and methods of measuring emotion. So this allows us to look at, so THETA mentioned this earlier, one of my students, THETA's on this project, one of my students is developing a visualization of herd immunity. So how does herd immunity work? And we're looking at, okay, are people noticing as the infection moves from one person to another? Is there level of stress? Is there emotional arousal, which is a measure of strong emotions, so stress, fear, those sorts of things? Is it increasing when the infection moves towards vulnerable people, et cetera, et cetera? So these are methods that are available and they are increasingly affordable, but they are not absolutely strictly necessary. But what this allows us to do is to look at things in detail, and this is where I really get to geek out on the human-computer interaction side of things with research, where we can look at things like, okay, what are people looking at? What do we see in terms of the emotions that they're experiencing when they're looking at that? And what does that mean in terms of how we might want to refine this design? So I keep hammering this, and the reason I keep hammering it is because it's one of the things that I find in health research the most important to take away from this, is that seeing how people respond and hearing what they think are different things. And I've always really liked this quote. If I'd asked people what they wanted, they would have said faster horses. This is attributed to Henry Ford. When I dug into it, I realized I learned that actually there's no record of him ever actually saying this, but everyone agrees it's the kind of thing he would have said. Another thing to know is that user testing doesn't test everything. So what user testing gives you is data about how easy something is to use, so the usability, and how people feel when they're using it, the user experience. But it's less good for things like functionality, which is basically, does the thing do what it's supposed to do? Does this intervention work according to the specification? It's also less good for accessibility, which means, is it usable by people who face barriers? So for example, if someone has color vision deficiencies and they don't see colors the way everyone else does, you're not going to pick that up unless they happen to be one of the testers who comes and participates in your study. And it also is not great for, it's not enough for testing whether or not something can be implemented. So it's an important aspect of whether or not something is implementable, but it's not all of what makes something implementable. So a couple of recommendations if you're ever developing an intervention and you're going to do some user testing. This is what I have everyone, we do this in all our projects in the lab now, where we make a table with 5 columns. And the first column is the design element, and the second is the effect that we want it to have. And so that we do before the study, before we run any testing. And that second bit, like the effect that you want this element to have, is a really useful design exercise anyway. And then following, what we get is what people got from this element, how it made them feel, and other comments and key quotes. And it's just a really useful way to capture data that becomes relatively straightforward to move into a paper. So when you're doing this kind of design work in an academic setting, we found that this particular tabular format is a really good way to collect data. And this is basically hypothesis testing your design, right? You've got an intervention, you want it to have such and such effect. And so being able to test this in an iterative way and to sort of iteratively refine it is a really powerful way to improve the intervention. And once those data are in, then analyzing the results basically means looking at the table. Is there anything that people aren't getting or reacting to in the way that you want? Anything that's confusing? Something that is often done is you make a list of issues and note how severe they are, because you can't always address everything. And it's important not to just, completely scrap everything and go back to the drawing board every time. And learning what you can learn about what the results tell you about your users' needs, goals, strengths, limitations, and intuitive processes. Plan the changes for the next iteration, and then do it again. So how many times? So this is something that I've always wondered about. There are no evidence-based recommendations for this that I've ever been able to find. And so I ran a study in which we were hoping that we would get data from this. We had some effect sizes, but we weren't able to get enough data to really determine this. And so what I decided to do was we ran a modified Delphi, so basically a study in which we go and we ask a lot of experts, and we run iterative consultations in which we hope people will sort of converge onto an answer. And so we ran 3 cycles with about 25 people who participated in the whole thing. And what we converged on is that in terms of when you're planning a project and you want to do iterative cycles, 2 to 3 cycles is the absolute minimum. And 2 is really pushing it. 3 is really better. 4 to 6 cycles is ideal. So if you're planning a project and you're thinking about timing and you're thinking about how many iterative cycles to do, thinking about, okay, how long would it take to do 6 different iterative cycles is important. This may vary depending on how you count a cycle. So if you're developing software and you're using a method like Agile, cycles are defined a little bit differently. How many people? So from a project planning perspective, this is also always a really important thing, like how many participants are you going to need to recruit? And what the Delphi converged on is that per round, per cycle, you need at least 5, but 10 to 20 is better. Total number, at least 10 to 15, preferably 20 to 50. So you will see a lot of recommendations in the literature. I couldn't want to review grants. I see a lot of people citing Nielsen and Verzi who say 3 to 5. And people will say things like 5 users will detect 85% of usability problems, and then cite this paper. That is only true for certain kinds of interfaces. So just being aware that that isn't a perfect estimate. It is not strictly necessary, but it's always ideal to bring in new people depending on what it is that you're developing. If your intervention is going to be something that a lot of people will see for the first time, then you want to be bringing in new people who haven't seen it before. Because if you just show the same thing to the same people over and over again, then their reaction is no longer the same reaction as people who would be seeing it for the first time. In terms of logistics, this has always been, I've always found this to be a somewhat challenging method to work with research ethics boards. And I love talking to people in industry who do fun things like design sprints, which sounds amazing, and I've participated in them as a participant, but we can't do that because we have to show things to our research ethics board before we can do another cycle. So what I have found over the years is that research ethics boards, they want to see all the study materials, but the materials change between cycles. And so what I found to be a good compromise is to commit the early designs. That's one of the reasons that we try to get sketches done as soon as possible. And we commit to submitting amendments for content changes, but not format changes. And that has been the way that we've been able to work with this in a way that is actually somewhat reasonable so that projects don't take 18 months. We try to run 1 cycle per month between the RUB dates. And when I've described user testing, the thing that seems to be the most, the light bulb goes on is it's like a cognitive interview. A cognitive interview is something that is often done in psychology. So the last thing that I'm going to talk about today is a measure that we developed in one of these projects that I talked about. And this project was essentially 3 interlinked systematic reviews with a lot of literature. It was a big project. But what we came up with was we had detailed descriptions of 390 projects, 348 of which we had all the development data. Like, this is how they developed their intervention. And so we took those data for these 348 projects, and we prioritized items using that framework of user-centered design, and then ran a bunch of psychometric analyses in which the psychometric data were pretty solid. We have a nice, very, very respectable scores here, which gave us this measure, and it's a descriptive measure of user involvement in developing an intervention. So there are 3 factors in this measure, and the first one, and all the items are basic yes, no. Did you do this or did you not? So the first factor is pre-prototype involvement. So were people involved in steps to understand users? And there are lots of different steps that could be done there. Were they involved in steps to develop a prototype? The second factor is iterative responsiveness. So were people asked their opinions, observed using the tool, observed in steps intended to evaluate the tool? Did it have 3 or more iterative cycles? And were changes between iterative cycles explicitly reported, which we think is probably like a proxy for taking iterations seriously. And then the third factor is other expert involvement. So were health professionals asked their opinion, consulted before the initial prototype, between the initial and final prototype, and was an expert panel involved? So this is a descriptive measure. It's not a normative measure. It's not a you must do all these 11 things. But it provides us with a way to sort of quantitatively describe these processes. And so that was sort of the end of that particular study of validating this measure. This measure has since been used in a study of online applications for children's pain. And there was, this study looked at, it was a systematic review of online applications looking at what contributes to those applications still being available. And I just realized I didn't put the citation up for this, but this is Perry Tutelman, Tutelman, and Lindsay O'Higgins, and Christine Chambers is the senior author on that one. And what they found was that applications that scored higher on this measure were also more likely to still be available and still be acceptable for people to use. So I think what that probably means is that people who do things well overall tend to do these kinds of things and tend to make sure that the thing that they developed is still usable by the people for whom it was intended to be used. But that remains to be seen. That's my particular interpretation of this. So the takeaways about user involvement for you for today are, first of all, always being clear about goals when you're designing something, when you're designing an intervention. What are the goals and whose goals are they? Failing early and failing well, so seeking negative results as soon as possible. Listening to people, but also using methods that don't require people to precisely articulate their difficulties, thoughts, needs. And when partnering with patients and caregivers, really what it comes down to is respect, building relationships, and kind of the golden rule. So treating other people how you would like to be treated. So thanks very much, and I welcome your questions.
Yes. Hello. So I'm going to change my introduction.
Yes.
To say that I am a patient partner in CORI, in CIHR. I've been on advisory boards, et cetera, and it's a very rewarding experience. I think there's one thing that you probably all know but was not articulated here, and that is because we patients are strangers in a strange land and coming into this all new, we often have expectations of deliverables, or that our agendas, for lack of better description, is going to be honored and followed. And the number of times I've had someone say, that's great, but it's not feasible. That's great, but it's actually not what we're here for. That's, et cetera. And it can get discouraging. So My best training was when I was a public member on the College of Occupational Therapists, and there was a half day of orientation that really spelled out, even though during my 2 terms there were still things that came up that they said, sounds good, Kathy, but can't be done, but that were more specific about the goals and the possibilities, and it avoided, as you can imagine, frustration on both of our parts and unrealistic expectations. So I have no doubt you who have worked with patients know that already intrinsically, but for you who are starting to work with patients, we can be an obstinate, self-centered, out for ourselves lot because we don't know any better.
I think it's reasonable to have expectations, though, and I think, thank you for articulating that. I think this is what we meant there by the third one. Like, clearly state individual and project goals, and maybe expectations might be a better way to frame that. Thank you.
Perhaps to add that, this is just, focus group of 1, N of 1, but the patients that have also been in the groups, we have debriefs afterwards, and it was, that's not what I thought this was going to be, or I thought I could have more. I just caution that, because I think every researcher that I've spoken to who's involved patients has been nothing but enthusiastic about it, even with the bumps going forward, nothing but enthusiastic. Thank you, Beth. Yes.
To my surprise, the question I was going to make actually leads very well from that very last sentence you made. You mentioned ethics very briefly, and you rapidly left the subject.
It's scary. It's a very scary subject.
It is indeed of both and a major interest. Anyway, the relationship with what you said was that the top of the list of ethical concerns is easy to state, not so easy to deal with, and it's called vested interest. And of course, patients have vested interests, probably not quite on the same scale as the pharmaceutical industry or so on, but it has to be dealt with, especially in the kind of work you're doing, because it clearly is subject to vested interest bias all over the place. And what has become very clear by some very reasonable research recently is that it's very difficult to design vested interest completely out of anything, because, I mean, the classical example is the doctor who's having a nice weekend on a cruise from a pharmaceutical product, genuinely believing that they're going to come off that, and if you ask them, they'll say, oh, that makes no difference whatever in my prescribing patterns. But the research shows clearly that it does. And so, yeah, I know you've only got so much time on a presentation like this, but I really think you got to deal with that issue, as best you can, because God knows we've been very slow and difficult about dealing with it as a profession in hospitals and universities. We're finally getting around to it, but even there, it's still relevant.
Yes, no, that's a very good point. Thank you. And I think, partly for me, it's because this isn't my ethics. I'm not an ethicist. It isn't my area of expertise, so I don't feel comfortable saying, hey, this is what everyone should do and this is how you should think about it. I will say I have learned a lot from my colleagues who are ethicists, and also from my colleagues who are not ethicists but who specialize in qualitative research. And I think one of the things that I heard early on that really sort of went, oh, right, is that, I remember hearing this argument where someone said, well, that patients have a vested, I don't think vested interest was the term they used, but it was similar to that. Patients have a vested interest, but everyone has a vested interest. Everyone at the table is bringing their own particular subjectivity to the table. And so what I've learned from my colleagues who do a lot more qualitative research is that to be much more explicit about the subjectivity and to be reflexive about it and to talk about it amongst ourselves. And, like you said, I don't think there's a perfect way to get around this, but You know, I think conflict of interest with pharmaceutical, that is a different kind of thing. You can, to a certain extent, make rules around that, but some of the other sticky bits, I don't, like you said, I don't think you can entirely get them out. So I think being more transparent and reflective about it is the best we can do, I hope. All right.
Very nice talk. And I really like the way you finished also, because I think treating people with the golden rule and a basic level of civility is what underlies all of it. But I also think that maybe people are not as critical about things like patient engagement in research as they potentially could be. And I think this is a really welcome trend. It's really important. But I'm just wondering if you could talk a little bit about if you have any experiences in which it's been actually a bad thing, you know, where patients have been harmed, or the research process has been harmed, or the process has been less efficient, or, you know, like, are there any downsides to more, you know, thorough, complete engagement with patients in research?
Yes. Yeah, no, great question. And I would agree. I don't think that people are as critical, and partly I think it's delicate, right? It's a delicate thing to say, well, this can be bad, right? Lots of things in research can be bad. Lots of things can go poorly. I think sometimes it isn't even necessarily about patient engagement per se, or patient-partnered research per se. It's that those particular people did not work well together. I have not personally had any bad experiences, but I've observed bad experiences, particularly in cases where people are just not comfortable bringing up issues. And one thing that I've seen a lot is where a patient partner will raise an issue and everyone in the room is really uncomfortable, but no one says anything. I remember being at I gave a talk once in Washington, D.C., and one of the other speakers had been talking about breast cancer screening. And there was a woman in the room who stood up and she identified herself as a breast cancer advocate. She'd run a breast cancer organization for 20 years. And she said, and I'll tell you why, something like, I'm not quoting it exactly, but what she said, something to the effect of, I'll tell you why women still want screening, is because we know that screening saves lives, right? Whereas the science is actually it doesn't actually support that very well in that particular situation, but no one was comfortable saying anything, right? And so I think one of the things that I think, and I had this conversation with someone this morning, we met for coffee and we were talking about the idea of being precious with patient partners. I think that that's actually a form of disrespect. If the patient partner is not willing to tell the researcher, hey, no, that's not working, and vice versa, that is a sign of lack of respect, and that's not a good relationship. Having said that, it's difficult to build a relationship, but like you have to build the relationship before you get to the point where you can have those kinds of honest conversations. But yeah, I agree. And I do think sometimes what I see a lot of, and I think Kathy spoke to this too, is that like when people do the box ticking exercise, that is a waste of resources. It's a waste of people's time. It's a waste, and it's a waste of really valuable time and valuable perspectives when you bring people into a room just to have them sit around the table and tell their story, and you're not going to do anything with that information. That's not okay either. So I agree. I think there are some real problems. And I mentioned this very briefly, but there's sort of this professionalization issue that I haven't completely wrapped my head around. And I, particularly as a person who lives with a chronic disease, who's also a researcher, sometimes I find myself in these weird positions where I feel concerned about whether or not it's valid for me to share my experience as a patient, knowing that my experience is no longer typical, right? Like when I go in to see my endocrinologist, we talk about the latest studies, right? And that's not the same thing, and I'm treated differently. So I don't know, that was a very rambling answer to your question.
Good.
However, to your point, I have been in situations where what you brought up, that there's no feedback loop. and then we're all pissed.
Yeah.
That's probably not what you were thinking of.
Well, no, I mean, I thought a lot about this in the context of health technology assessment, and there's a real trend towards getting patients more deeply engaged at every level. Picking the questions, reviewing the data, and weighing in on the recommendations. And it's a bit hard because on the one hand, patients' perspectives are very valuable, and yet on the other hand, there's a certain level of technical expertise that's required to actually engage as equals in these kinds of discussions. And then if you train patients to the point where they're technically as proficient as the experts, you've kind of lost the whole point of working with patients. So there is a balance between kind of letting the patient speak with authority on the areas in which they are authorities, and also giving enough. So this is, again, I'm not a very concise response to your question, but I just think that there are circumstances in which it is not straightforward, and there's certain types of questions in which patient engagements are more useful than others. And oftentimes some kind of level of training and technical facility is required to make it actually a productive relationship.
There was a really interesting systematic review. Oh shoot, I'm blanking on the author's last name. It was published in Serious Games in JMIR, and they looked at how patient partners were involved in co-designing serious games to help with behavior change. And what they found was that it was helpful when people were involved in articulating the problem, and it was unhelpful, like it reduced the effects when people were involved in co-designing the solution to that problem. So, sorry, I think there's someone else.
One question from online participant. Lorraine Puri is asking, do you think that user needs assessment or user testing should always use theory-informed approaches? Are there circumstances where it's much more necessary?
I have mixed feelings about theory. I think theory, when there are theories that are applicable to that situation, then yes, you should use the theory, right? Because you've got that theory and it's available and it's applicable. But there isn't always a theory for every situation, and so I don't think it's an absolute requirement. No.
Thank you.
In my opinion, ask different people, you get different opinions.
All right, I'm stepping a question because we're way over time, and I also know you have to catch your plane, and maybe some people have to leave. But thanks so much, Holly, and thanks so much, everyone, for coming. And maybe she can say.